problem of the hypertension and development of the dementia. This is not new problem because clinical investigations published longitudinal studies have been published 20 years ago. And nowadays we are, in my report, I would like to highlight more practical questions related with practical clinical practice. So as for epidemiological factors of dementia, here you can see that so the dementia is not it is not rare condition. This is this disorder is related with nowadays we can observe a sizably increasing of the prevalence of the dementia, and above mentioned epidemiological data can be explained by the aging of the population of all countries, and increasing of the age of population. It is related with the high prevalence of the dementia. According to the gender differences, according to the clinical studies, we can confirm that more frequent dementia has been revealed in the female part of population than male part of population. Factors as for risk factors for development of dementia, we highlight several risk factors. It is not related just with high blood pressure. First of all, the high level of the blood pressure, it contributes very much for high risk of the dementia. But except high blood pressure, the lower physical activity, cigarette smoking, level of the body mass index is also important. Considering that pandemic of obesity and overweight is present in all countries, most of countries, we can realize the high contribution of to development of onset of the dementia. Also, thyroid gland dysfunction can contribute to development of the dementia, and metabolic disorders, metabolic syndrome, type 2 diabetes, abdominal obesity, they are also important risk factors. According the next question is the clinical manifestations, clinical signs of symptoms of dementia related with cognitive decline, and that's why this is not only medical problem. This is this is medical problem. It involves social parts of our life, and clinical symptoms of the dementia is well known, but I would like to highlight additional symptoms like slow gait. And now you can see results of investigation that confirmed that slow gait has been associated with cerebrovascular lesions, and patients with cognitive decline with slow gait, they have been confirmed presence of the morphological changes in the brain tissue, like global burden of white matter, hyperintensities, and it's very important the localization in the frontal part of predominance frontal distribution, and also occipital localization, which part of the brain is responsible for coordination of the human body. Moreover, the patients with low gait have been confirmed by lacunar infarcts at brain. So that's why we conclude that cognitive decline, this is not only a clinical symptom. This is, clinical syndrome, it is accompanied by appropriate changes in the brain tissue. Now, I would like to highlight for risk factors for dementia, and unlike endocrine, unlike bad habits and metabolic risk factors, I would like to highlight the focus our attention at the hypertension, presence of the midlife hypertension, and it's very important uncontrolled hypertension, because you know that according to the rule of half rule, approximately half of population of adult population, they're having high blood pressure. Among the hypertensive patients, approximately half of them, they are unaware about presence of the high blood pressure. So that's why hypertension, it is remaining undiagnosed. Moreover, in those group of patients with presence of the high blood pressure, just half of them, they are receiving antihypertension therapy. And from among patients with hypertension receiving antihypertension therapy, just half of them, approximately 40, up to 50% of them, they are having achievement of the target level of the blood pressure. So that's why the importance of the hypertension in the development of the dementia, it is very highly important and confirmed. And association of the hypertension with cognitive disorder has been already confirmed in prospective longitudinal studies. Now I would like to remind you prospective longitudinal epidemiological study on aging population of Honolulu, and we can see that up to so untreated high blood pressure patients, they have been significant increasing risk of the development of the dementia. So we conclude that untreated high blood pressure, this is a very important serious factor, risk factor for development of the dementia. But above mentioned Honolulu study was performed in American population. What about another subgroup of patients? For instance, this is another large investigation. It was longitudinal population-based study of elderly individuals living in the Europe, in western part of the Europe, and researchers, they have examined whether initial high blood pressure and the administration of antihypertensive treatment predicted the onset of the cognitive decline. So to be honest, it was a prospective study of during 4 years, more than 1,300 patients. They have been included, and cognitive decline was defined as a drop of at least 4 points and more in the mini mental state examination. So, and this prospective study confirmed relationship with association of the uncontrolled high blood pressure with the risk of the development of the dementia. That's why we conclude that treatment of the hypertension pharmacotherapy or the on-time pharmacotherapy of hypertension can be very reasonable and useful treatment to prevent development of the dyspnea, right? Dementia. But we have another question. When we speak about the patients with cognitive decline, the average age of those patients, it is usually older than 65. This is a subgroup of population of patients with older age. That's why as a practical doctor, we should ask another question. What target level of the blood pressure should be used? So there is so we have to we have to meet with the clinical dilemma question. On the one hand, we know that targeting of the achievement of the target level of the blood pressure level in the antihypertension therapy, it is important and useful according official clinical guidelines, right? On the other hand, we should take into account clinical properties of patients with hypertension. We should consider disadvantages of of antihypertension therapy in old age, because old age patients, they have this is specific vulnerable part of population, because they might suffer from intolerance from antihypertension therapy. And intolerance of the antihypertension therapy it can be manifested by hypotension, orthostatic hypotension, syncope, falls, and fractures. Above mentioned dramatical results have been published in large longitudinal study published in the Irish colleagues. So that's why it is. That's why we should check carefully the target level of the blood pressure. You know that according another clinical studies, it's very important that over decreasing of the blood pressure in old patients with hypertension can be accompanied by hypoperfusion of the vital organs, first of all brain and kidney. That's why, based on results of studies including older patients, it is not possible to proclaim universal targets of the level of the blood pressure for all 100 patients with arterial hypertension with old age. That's why we have the practical question: what target level of the blood pressure should be used for treatment of patients with hypertension at old age? Or as a practical setting, we usually refer to we should use evidence-based internet sources, medical literature. That's why we refer to clinical guidelines. Now at this slide, I have provided. I put several clinical guidelines from the American Heart Association, from European Society, and from Russian Society of Cardiologists. And as you can see, the threshold of the blood pressure for patients with high blood pressure in according American Heart Association, it was recommended lower threshold 130/80, but patients with cardiovascular disease. But now I would like to highlight your attention for the second row. This is blood pressure targets for patients, older patients, 65 and more. 65 and older patients, you can see that they have another different target levels, and the above mentioned target levels have been provided according appropriate investigations of different ethnicity patients with different ethnicity. And American Heart Association colleagues, they offer more aggressive therapy, and more lower level of the target level of the blood pressure level. It was published less than 130 systolical blood pressure. According to the Russian Society of Cardiology, less than 140/90. And patients with older than 85 years old and older, they have higher level of the target level of the blood pressure. But above mentioned target levels of the blood pressure should be considered according to the presence or absence of the frailty syndrome. Patients with the frailty syndrome, they deserve a higher level of the target level of the blood pressure, because patients with the frailty syndrome, they are having over decreasing of the blood pressure in frailty syndrome patients. It is not recommended from the clinical point of view. It is not reasonable due to considering high risk of the falls and fractures and high risk of the development of the dementia. So we conclude that patients with dementia, cognitive decline, they should be treated carefully, considering the presence or absence of the frailty syndrome. Patients with frailty syndrome, we must we must use monotherapy, not a combination of the antihypertension therapy. For second recommendation, we should use lower doses of the antihypertension therapy to avoid of the over decreasing of the blood pressure. So, and in the conclusion, patients with midlife untreated hypertension, they are having very highest risk of development of the cognitive decline. And second conclusion, aggressive blood pressure lowering and the duration of the antihypertension therapy reduce the incidence of any form of dementia. But there is a very important notification that reducing of the blood pressure in old age patients should be individualized to prevent complications and to prevent decreasing of the cognitive function. Thank you very much. Do you have questions?
Thank you, Alina. Thank you for your very nice presentation, very comprehensive and very interesting topic on the dementia problem. Because of the third speaker cannot join this meeting, so we may have more time for our discussions. I think our audience can, if you have any question, can please show up and raise your questions. Maybe I can start first. Alina, it's very nice presentation. I'm wondering that how to treat different kinds of causes of dementia, because we have Alzheimer's disease and also vascular dementia, with different types of dementia. So how to treat that? Is antihypertensive treatment effective in the patients with Alzheimer's? Alina.
Thank you very much, Professor. So treatment of patients with developed dementia, this is not a question for one doctor. This is my multidisciplinary approach should be used for management of such group of patients. And the multidisciplinary principle, it means involvement of different specialists including neurologists, including nutrient specialists, and kidney nephrological doctors, and vascular specialists, and several. So, and as for management of the Alzheimer disease, the antihypertension therapy should be used, but with adjusted level of the target level of the blood pressure, because on the one hand, patients with Alzheimer disease, they have already had severe cognitive decline. On the other hand, due to ethical questions, we should maintain antihypertension therapy in order to prevent development of the cardiovascular complications like acute coronary syndrome and heart failure, progression of the heart failure and stroke. That's why this is an ethical question, and medical and ethical question. And of course, multidisciplinary approach should be used according recent clinical guidelines and clinical consensuses.
Thank you. Any more questions from our audience or co-chairs?
Yes, if I can ask the questions, Alina, a very good presentation, and I enjoyed very much. And I have one question regarding that you mentioned the Russian hypertension guideline recommended the patients aged over 65, the target blood pressure for this population is 140 over 90%, 90 millimeter mercury, and also for the patients aged over 85 years old, that is higher, like 150 millimeter mercury for systolic blood pressure target. So I do not know if you know some reason for this, or some trial specified in the Russian population to indicate that they have the higher blood pressure targets for this population, or any other concerns like the temperature. I'm not quite get this point, so it's a little questions.
Thank you very much. So this, we know that all clinical guidelines is usually written by the total common agreement and conclusion of multiple prospective and studies, or might be randomized control studies, or maybe observational studies.
Yes.
And above mentioned clinical guidelines published in 2024, it was based on the results of investigation of patients living in the Russia.
Okay.
And I have included this clinical guideline because Russia, this is the nearest neighbor of China, first of all.
Yeah.
On the other hand, large population. Perhaps local. So the above mentioned, I have had conversation with the authors of this guideline, and they have used results of their own investigations first.
Okay.
And second one, they have received very alarming results according high prevalence of the frailty syndrome in older people. You know that average lifespan in the Russia is approximately 77, I guess, less than 85. And the people older than 85 years, they are having highest risk, extremely high risk of the frailty syndrome. And majority of them, they have already confirmed this frailty syndrome. That's why they have, I guess they have adjusted the pros and contra of the benefits and disadvantages of the antihypertension therapy, and they considered very severe complications of the outcomes of the frailty syndrome. That's why they proposed another targets.
Okay, thank you very much. And if I can add another story that's regarding for the dementia, and because you mentioned that the middle life hypertension is associated with dementia, and more recently there are some publication in hypertension. I think about several months ago, the authors mentioned they have the investigation. I forget the population, but I remember that very impressive that patients at childhood stage, that the systolic blood pressure area on the curve, that it showed the systolic blood pressure burden like over 20 years is also significantly associated with the middle life dementia. So maybe it's more early that for the hypertension burden has some association with the dementia. It's very important. And another important issue that is also the genetic. I think the genetic also play an important role in the dementia. There are some publications indicated, I think in the UK Biobank, the database that indicated that the polygene risk score also have some very significant influence on the late life dementia. So also we need to take both of this into concern in our clinical practice. So I just want to add two concerns that from mine. Thank you.
Thank you.
Okay, any questions from co-chairs and colleagues? To follow up with the John's question on midlife blood pressure management, do you propose that we may recommend a relatively strict blood pressure target in the midlife, or maybe something like 140, 130, over 80, or even lower? Because some studies even shown that blood pressure less than 120 will be maybe beneficial for some patients. Not necessarily for the reduction of dementia, but for the overall cardiovascular events.
Yes, I think because if we take a look at the most population study, that it indicated that 150 may be the best target for the human blood pressure. If it's over 150, it is treatable, maybe, but actually we do not have trial to indicate that in this stage we use drugs to decrease the systolic blood pressure will have the late life prognostic benefit. So I still have doubts that maybe the ideal blood pressure level for human, even in the middle life, is 115, but I do not think they need treatable. If we have more data and the trial that indicated with drug that they have the net benefit, prognostic benefit, I will believe it. So so yes, ideal blood pressure and treatable blood
yes,
pressure is another issue.
Yeah, I agree. Okay, maybe we can move on, and maybe Alina, you can chair the next speaker. Alina, please.
Should I still?
Yeah.
Dear colleagues, it's a high privilege to me to pronounce next speaker, Dr. Yu Chen, the Rujin Hospital affiliated to Shanghai Jiao Tong University School of Medicine. The report, the presentation is exercise-induced blood pressure and cardiac structure and function. Please, Professor.
Hello, everyone. I'm Chen Yi from the Shanghai Institution of Hypertension. Here's my slide. Can you see it?
Yes.
Okay. Hello, everyone. I'm Chen Yi from the Shanghai Institution of Hypertension. It's a great honor to participate this meeting of Asian Heart Society, and I'm very pleased to I'm very pleased to share this interesting topic with you all, that is exploring the relationship between the exercise-induced blood pressure changes and cardiovascular structure and function from the perspective of wearable devices. As we all know that exercise is a cornerstone of cardiovascular health, and blood pressure fluctuates dramatically during the physical exertion. Existing research tells us that at volitional exhaustion or when reaching the 85th% of the age predicted active pulse rate, systolic blood pressure, systolic blood pressure increased on average by 40 to 60 millimeter mercury, while the diastolic blood pressure often remains stable or even decreased slightly. A large number of studies has shown that an exaggerated increase in exercise-induced systolic blood pressure may provide incremental predictive values for cardiovascular alterations, events, and mortality. The Framingham study, with about 3,000 participants whose follow-up for 20 years shows that the subjects with the systolic blood pressure above the 80th percentile were associated with significantly greater risk of cardiovascular events, as shown in the left picture So therefore, effective monitoring of blood pressure and pulse rate during exercise is crucial for early identification of cardiovascular risk and ensuring the safety of exercise. Now, measuring blood pressure during exercise has always been a bit of a challenge. Think about the traditional arm cuff. They work great when you are sitting still, but when someone is pedaling a stationary bike or running a treadmill, you get motion artifacts, inaccurate readings, and frankly, it's not just practical for continuous monitoring. That's where the wearable tech step in. Devices like the Huawei Watch D2 are designed for the ambulatory monitoring, offering a more seamless way to track these dynamic changes without interrupting the exercise itself. So what did we set out to do? Our primary goal was to rigorously test if this wearable risk monitoring could actually capture the meaningful exercise induced blood pressure and pulse rate changes, and crucially, whether these changes tell something about the heart's underlying structure and function. We designed a cross-sectional study recruiting participants with individuals have hypertension or normal blood pressure. They underwent a standardized symptom limit exercise test on a cycle egometer. And using the Huawei Watch T2, we capture blood pressure and pulse rate at rest, peak exercise, and during recovery. Let's look at who participated in this study. We have 137 individuals with an average age of 36.7 years old. Importantly, we include both men and women, with a significant portion, over half, have hypertension. This diversity helps us ensure our findings are broadly applicable. The exercise protocol are standardized using a ramp protocol on a cycle egometer, pushing the participants to their symptom limit or reaching 85% of their predicted maximal heart rate. Throughout the process, we meticulously recorded the blood pressure and pulse rate at key points before the starting, at the peak exercise, and at the peak of their effort and as they recovered. So what did we find when we look at the raw data? As expected, systolic blood pressure shoot up significantly during exercise, average 31.7 millimeter mercury increase. Diastolic pressure, however, barely budged, only rising by about 5 millimeters mercury. pulse rate, on the other hand, we saw a dramatically jump, increased by nearly 63 beats per minute on average. And importantly, after stopping the exercise, both blood pressure and pulse rate gradually returned towards their resting levels. The blood pressure in hypertensive patients were significantly higher than in normotensive participants at the basal, peak exercise and recovery, while the pulse rate at peak exercise was slower in the hypertensive patients. Now here's where it gets really interesting. We calculated systolic blood pressure reserve. That is essentially the difference between the peak exercise blood pressure and the resting systolic blood pressure. What we find was a significantly positive association. As shown on the left side of the table, individuals with a higher systolic blood pressure reserve tended to have larger cardiovascular cardiac structure, especially thicker ventricular walls and increased left ventricular mass. This suggests that exaggerated systolic blood pressure response during exercise might be a sign of underlying the cardiac structure remodeling. The picture for pulse rate reserve was different. We saw a negative association with cardiac structure and a positive link to diastolic function. As shown on the left side of the table, lower pulse rate reserve was corrected with a larger heart structure, and pulse rate reserve was positively linked to diastolic function, measured by the E/A ratio. This implies that individuals whose heart rate doesn't increase as much as expected during exercise may have impaired diastolic feeling, which could contribute to the exercise intolerance. An intriguing observation emerged when we analyzed the data by sex. While the statistical significance was not absolute, the trend suggests that the associations between these exercise hemodynamic responses and cardiac parameters were generally stronger in women, as shown by the line formed by the blood dots in the figures. So why might this be? I think we think several factors could play a role. Women often have higher arterial stiffness and potentially smaller left ventricular size and hormonal influences. All these factors could make the women's cardiovascular system more sensitive to the hemodynamic stresses of the exercise, leading to more pronounced changes in blood pressure and pulse rate reserve. So, what's driving these associations between the exercise responses to cardiac changes? The underlying mechanisms likely involve the following points. The first is the increased arterial stiffness. Common in pre-hypertension impairs the proper vasodilation during exercise, maintaining high pressure on the heart. Second is the endothelial dysfunction. Reduced nitric oxidation ability further hinders the vasodilations. So, additionally, excessive sympathetic activation also plays a pivotal role. So, what does all this mean clinically? First, it reinforces the values of wearable blood pressure monitors. They aren't just for resting measurement. They can effectively capture the dynamic hemodynamic responses during exercise. Secondly, these findings suggest that the exercise-induced blood pressure and pulse rate reserve could be novel markers for identifying the individuals at risk for cardiovascular issues, potentially offering early insights than the resting measurement alone. Looking ahead, larger prospective studies are needed to validate these associations and exploring how we can leverage the data from the wearable devices for the personalized cardiovascular risk assessment and health management. Of course, our study has limitations, including a relatively small sample size, potential motion artifacts issues, and the cross-sectional nature of our design, which prevent us from making definitively causal claims. So, however, the key takeaway is clear. Here's the conclusion. The first is wearable blood pressure monitor can effectively track the exercise-induced hemodynamic changes. The exercise-induced blood pressure and pulse rate reserve are associated with cardiac structure and function. These specific associations underscore the potential value of incorporating the dynamic testing and wearable tech into the cardiovascular profiling. So this is my research presentation. Thank you. Thank you.
Thank you very much, Professor. Dear colleagues, do you have questions to this presentation?
Yes, if I may ask the first questions. I do not quite get the exercise systolic blood pressure. If the patients wear it in a normal life or for the treadmill or something to do the. I mean that if the patients reach the peak aerobic capacities, that is to say, the peak exercise level for these patients in order to evaluate the exercise systolic blood pressure. For instance, if I walk like 10 minutes, it's exercise, but my systolic blood pressure will increase like 10. But if I do the jogging or running very fast, that means I will reach the peak exercise systolic blood pressure. So it's a little different. So I don't know in your population if the patients reach the peak capacity of the exercise.
The peak exercise, when we measure the peak exercise blood pressure, we encourage the participants to exercise to the we have a symptom limit exercise. So when so what is the end of the exercise? We wait a minute. We have a standard symptom limit exercise test on a cycle egometer. So when the people have reached the 85% of their the maximum of their maximum pulse rate, so we can tell the participant to hold it. Then we take the peak blood pressure measurements.
Yeah, I think it makes sense because that if the patients reach the highest pulse rate, like 150 for people aged like 40 years old, that is almost the peak, and then the exercise systolic blood pressure may be the maximum. Why I ask this question? Because I read one article in JACC maybe several months ago. It's called the exertion study. It is indicated that the exercise systolic blood pressure do not predict the cardiovascular prognosis. But if you do the exercise systolic blood pressure divided by the peak max, that is the aerobic capacity or the fitness, then you will find a significant results to show that if we consider the fitness, because people like aged people that they cannot reach the very high heart rate, or the sports exercise limitation for this aged population is relatively low. So if you consider the fitness, and also the exercise system blood pressure, you do the deviation that will show better parameter for the prediction. So that's why I asked this question. Okay, thank you for your presentation.
Thank you.
If I can follow up on the first question that about the blood pressure measurement device you used when Huawei Watch D2, it's an excellent device. I know that, but the problem is that we often use the exercise blood pressure with the traditional treadmill test, or more recently on cardiopulmonary fitness test. These two types of exercise can be used in evaluation the capacity of exercise for patients, AO patients or relatively healthier, and to guide their exercise. But at the same time, they measure blood pressure. So my question is how to calibrate these two type of exercise blood pressure measurement with Watch D2 doing the same exercise or similar exercise.
So how is the two different exercise, treadmill or
cardiopulmonary test? We use this to exercise test in evaluation the patient's ischemia, cardiac ischemia. At the same time, they measure blood pressure, and often we use this blood pressure to as the value of exercise blood pressure. 2020 or 2100 or 2000 something like that's a higher limit for a male subject, maybe 190 for the female subjects as the higher limit. But the Watch D2, do you calibrate with this kind of two type of exercise? I mean, treadmill, cardiopulmonary test to compare to the
we only tested the Huawei Watch D2 on the cycle ergometer. So as you can see in our results, the blood pressure, the systolic blood pressure rise about 31.7. That is lower than the we actually know in the previous research, that is 40 to 60 millimeter per mercury. So I think the wearable risk monitoring have some some limitations in reaching this peak exercise blood pressure monitoring. So and the other question. The other answers is that in our Huawei Watch T2, we can only monitor the blood pressure when they stop the exercise. So that is the minute the one stops the exercise, we measure the blood pressure. So that is another limitation.
Thank you.
Thank you.
I have two small questions I want to discuss with Dr. Chen. The first question is, in your study, you combined with echocardiography and found the echocardiography parameter different. So the first question is, when was the echocardiography performed relative to the exercise blood pressure test? Was it conducted on the same day prior to exercise testing or at the separate follow-up visits? The second question is, in your study, there have two groups. The first group is normotensive subjects. The second group is hypertensive patients. Is there any difference or distinctions in cardiac structure modeling between these two groups? Thank you.
Thank you for the question. The first question, the echocardiography was measured within 2 weeks or 1 month when we tested the exercise blood pressure measurements. So they were measured very near. The time were within 2 weeks. The second question is that, as we showed in another slide, the hypertension in hypertensive patients, the blood pressure was significantly higher than in normotensive patients at basal, big exercise, and recovery, while the pulse rate at peak exercise was lower in hypertensive patients. So that is the difference between the hypertensive patients and the normotensive participants. Thank you.
Do we have time for one small question, short question?
If I can ask another question, because I'm very interested in the Huawei Watch D2, because it is now very popular to use this kind of the so-called the cuffless blood pressure monitor. I think it is worldwide now, but I don't know the accuracy of this blood pressure measurements. In your opinion, is acceptable for diagnosis and to titration of the patient's blood pressure medication? You think it is clinical, practical, that in routine practice? So this is my question. Just curious about this.
So the accuracy of the Huawei Watch T2 has been validated in another study, in our previous study, with the conventional ambulatory blood pressure, that is the AND blood pressure. So the accuracy has been validated in general population and for rest and ambulatory blood pressure measurements. So in our study, we just tested the blood pressures, the systolic blood pressure change and the pulse rate change with the cardiovascular parameters. So in another points, we tested the accuracy. If we can validate that this systolic blood pressure change can have associations with the parameter of cardiovascular with the echocardiology, so we can further validate this usefulness of the Huawei Watch D2. I think is the point of that. Yeah.
Okay, thank you.
Thank you.
Thank you, Professor.
Okay, I think it's my turn. That I'm so glad to have this chance to introduce the third speaker, Professor Qianhui Guo from Shanghai Institute of Hypertension, affiliated to Shanghai Jiao Tong University, and she is work in the Region Hospital, Jiao Tong University School of Medicine, and the National Research Center for Translational Medicine. And she is also the member of the branch of the Remote Intelligence Management of Chronic Disease, Chinese Society of Gerontology and Geriatrics. And also he chaired some NSFC grants and do several basic research and also clinical and population studies with several first SAI publications cited as the first also. So Dr. Qianhui Guo will give us the speech titled, yes, if we can have the title, yes, the Delight File. I think it's a RCT, so welcome. Yes, you can share your slides.
Thanks, Chairman, for your kindly introduction. Good morning, distinguished colleagues and the Chairman. I'm Qianhui Guo from Shanghai Institute of Hypertension. It's my great honor to participate in this meeting and present the results of a randomized controlled trial titled "The Cognitive Digital Therapy in Hypertensive Patients with Cognitive Impairment but No Dementia." This is a multi-center clinical trial jointly initiated by our institute and Beijing Anzhen Hospital. As we all know, cognitive impairment and dementia present a growing public health challenge in China. Cognitive impairment and dementia are syndromes characterized by acquired persistent cognitive decline, which will further lead to the declines in patients' ability to carry out daily living and working activities, as well as their behavior changes. Epidemiological survey published in 2020 have reported that the prevalence of mild cognitive impairment among Chinese adults aged greater and equal than 60 years were about 15.5%, where the prevalence of dementia reached about 6%. In addition, with the accelerating aging of Chinese population, the total number of patients with cognitive impairment and dementia is rising rapidly. The annual conversion rate from the mild cognitive impairment to dementia ranges from 10 to 15%. And as we all know, hypertension is a well-established risk factor for, established a risk factor for cognitive decline and dementia. A large population-based study using the National Health Insurance Service database of the South Korea have enrolled a total of 400,000 middle-aged and elderly hypertensive patients with systolic blood pressure greater and equal than 140 millimeter mercury. With a mean follow-up of 7 years. This study demonstrated that every 10 millimeter of mercury increment in the baseline systolic blood pressure was linked to about 20% higher dementia risk among participants aged 49 to 59 years and about 10% higher risk of those aged 60 to 69 years. And furthermore, another study published in JAMA compared the risk of dementia across individuals with different blood pressure types in the midlife and late life. And the study showed that compared with participants who maintained normal blood pressure throughout the midlife and the old age, those with chronic persistent hypertension starting in the midlife, as well as patients with elevated blood pressure in the midlife, but followed up by hypotension in the late life, exhibited a significantly higher risk of developing dementia. These findings highlight the importance of addressing cognitive health in hypertensive populations. However, at present, there are no definitive and effective pharmacological treatment for hypertension-related cognitive dysfunction. Multiple previous studies have explored the effects of intensive blood pressure lowering on cognitive impairments and dementia among hypertensive patients, but the results remained inconsistent. As shown in this slide, meta-analysis published in 2021 have demonstrated that the intensive antihypertensive therapy failed to reach a clear preventive benefit against mild cognitive impairment and dementia. But another meta-analysis published in European Heart Journal in 2022, concluded that intensive blood pressure reduction could lower the incidence of dementia. Computerized cognitive training is a novel non-pharmacological intervention for various cognitive disorders. Previous literatures have verified that cognitive training can improve the cognitive performance in patients with earlier Alzheimer's disease, mild cognitive impairment, and post-stroke vascular cognitive impairment. Besides the behavior improvements, the benefits of computerized cognitive training also reflect in both the structural and the functional alteration of the neurons. As shown in the right of this slide, a study published in the Alzheimer's disease and 2019 demonstrated a 7-week multi-domain cognitive training delivered via the tablet. They included 6 patients with vascular mild cognitive impairment and randomized to cognitive training or control group and follow up to 6 months. And they found that the cognitive training delivered via the tablets could significantly elevate their MoCA score in the patients with vascular cognitive impairment. And they also found that the cognitive training could improve the functional connectivity between the left dorsolateral and prefrontal cortex and the medial prefrontal cortex, which it will increase the connectivity, functional connectivity of this region of this field of the brain. But nevertheless, there is still a lack of research evaluating the effects of the tablet-based cognitive training and adaptive and non-adaptive cognitive training on the cognitive function and the relevant neural activities among patients with hypertension-related cognitive dysfunction. So our institute and Angel Hospital jointly launched this randomized controlled trial. This study was aimed to evaluate the efficacy of multi-domain adaptive computerized cognitive training as a potential digital therapeutic in improving cognitive function and inducing neural and physiological changes in hypertensive patients with mild cognitive impairment. This study is a multi-center, double-blind, randomized, and positive controlled trial. A total of 217 hypertensive patients with mild cognitive impairment were enrolled from 11 centers nationwide, and participants were stratified by age and education level, and then randomly assigned to either the adaptive cognitive training group or the non-adaptive active control group. The inclusion criteria included age greater and equal than 60, completion of 6 years of education or more, untreated or treated hypertension, compliance of cognitive decline in the past 1 year, and a MoCA score of less than 26, and consent to receive the cognitive evaluation, randomization, follow-up. The exclusion criteria included incapacity to complete the cognitive assessment or the training, documented diagnosis of dementia, or the MMSE score less than 24. Other exclusion criteria ensured safety and minimize the confounders such as diabetes, severe psychiatric diseases, and recent cardiovascular events. In this study, the intervention group, the adaptive computerized cognitive training group, will receive the multi-domain targeted electronic training. It covers attention, memory, executive function, thinking, processing speed, and perception multi-domain. And the training will adaptive adjustment of the difficulty and the training program based on patient's performance. And the positive control group received a positive control with fixed and lower difficulty training. Both groups trained at least 5 sessions per week for at least 30 minutes per session and over the 12 weeks. After 12 weeks, the cognitive digital therapy group will re-randomize to continue the training or stop the training until 6 months. The primary outcome of this study is the proportion of participants with improvement in the global cognitive function measured by the BCAT score increased greater than or equal than 2 points and 12-week follow-up. And the secondary outcome includes the improvement proportion in the BCAT subdomains, including episodic memory, processing speed, working memory, and we saw spatial ability. And the changes in cognitive abilities measured by MoCA and BCAT scores, and also the changes in anxiety and depression symptoms, self-efficacy, and quality of life measured by the neurophysiological scores. We also have exploratory endpoints to explore the neuroimaging changes in 43 patients who have underwent the 7 Tesla brain MRI scanning. This slide shows the flowchart of this study. Totally 217 patients were randomized, including 108 in the intervention group and 109 in the control group. This slide shows the characteristics of the study participant. The mean age of the participants was 69 years, including 124 female patients with a mean office blood pressure of 136/76 millimeter of mercury. There were no statistical significant differences in the baseline clinical characteristics between groups. The mean MoCA score was 21.35 and 21.7 in the intervention and control group respectively. The mean BCAT scores were 9.57 and 9.88 correspondingly. No statistically significant intergroup difference were observed in the cognitive scores assessment and the baseline. And the 12-week follow-up, 12.87% patients in the digital cognitive therapy group and 60.5% patients in the control group met the predefined improvement in the BCAT scores. But there was no statistically significant difference in the BCAT improvement rate between the two groups. In terms of the improvements in cognitive subdomains of the BCAT, there is also no significant intergroup difference were observed. We further assessed the changes in the cognitive function scores after training, and 12-week follow-up, both groups showed within-group improvement in the MoCA score and the working memory score, indicating that the multi-domain cognitive training, whether adaptive or non-adaptive, can produce meaningful benefits for patients' cognitive function. Besides, the intervention group also exhibited a significant improvement in the processing speed score, but there is no significant intergroup difference were identified. This slide shows the results and the 24-week follow-up. Continued training versus stop training did not show significant additional benefits in the cognitive measures. Both training arms maintained improvements in the MoCA score and showed benefits in the mood and self-efficacy. In the 43 patients who have underwent the 7 Tesla brain MRI scanning, we further explored the effects of the two interventions on the brain functional connectivities. Because in our previous analysis and formal other studies, ventral attention network and executive control network has been implicated in the brain-heart axis dysregulation and is prevalent in hypertensive patients with cognitive decline. So these two networks were selected as seed regions for examining the training-induced changes of the whole brain functional connectivity. As shown in this slide, compared with the control group, the intervention group showed significantly enhanced functional connectivity between the ventral attention network and the key regions of the dorsal attention network, executive control network, and the episodic memory network, as well as between the ECA and the EMN key regions. And in the network-to-network functional connectivity analysis, we also find significant group and time interactions of these key regions of brain network. To further validate our findings regarding functional connectivity, we also analyzed the structural connectivity by calculating the wet matter tract connectivity based on the key regions of within the above networks. And we can see that the training induced increase in the wet matter tract connectivity between key regions were more pronounced in the intervention group than in the controls. Furthermore, the gray matter volume analysis revealed greater training-induced gray matter volume increase in the hippocampus gray matter volume in the intervention group relative to the control group. All these results of the brain MRI demonstrated that the adaptive cognitive training may promote the neuroplastic in hypertension vulnerable brain regions, including the ventral attention network, executive control network, and hippocampus involved episodic memory network. In this study, 9 adverse events occurred during the study, but they were all unrelated to the study invitations. So in conclusion, both adaptive versus non-adaptive multi-domain cognitive training could improve the cognitive function in the global cognition and working memory in older hypertensive patients with mild cognitive impairment. Only the multi-domain adaptive digital intervention could improve the processing speed, suggesting a possible domain-specific advantage. And the multi-domain adaptive cognitive training produced more pronounced benefits in the brain functions and structural connectivity, particularly with the advanced networks and the hippocampus. And early intervention may help mitigate cognitive decline in hypertensive populations. This is my presentation. Thank you for your attention.
Okay, thank you, Dr. Guo. Thank you very much for your excellent presentation, and I think it's a very interesting topic and a very nice RCT study. Congratulations. And I think it's reached a very popular area or field in nowadays. It's called the brain-computer interface, BCI. In Chinese, we call it 脑机接口. Very popular, very hot topic. And I know that there are a lot of ground reaching this BCI field. So congratulations, you may have chance to apply for more funds in order to reach more research. Yeah, thank you very much for your presentation. I have one question regarding the inclusion criteria of this study. You mentioned that I do not quite get it. You mean that these patients only have the complaint about the cognitive empowerment in their life, or you also do the MMSE score or for the inclusion criteria? Because I read that there is no some score in order to indicate that patients will have the cognitive empowerment.
Thank you for your question. We have measured for the patients older than 60 years old with hypertension and complained about the cognitive decline in the past 1 year. We will give them the MOCA and the MSE test before the inclusion of these patients. MOCA was less than 26, was used in the inclusion criteria for the definition of a mild cognitive impairment, and the MSE was used for the exclusive criteria to rule out the patients with dementia. Yeah. We have did these measures before the enrollment of these patients.
Okay, I get it. So the patients also get the symptom and also have the mild cognitive dysfunction indicated by MMS and other scores. Thank you very much. And for better understand that, because for this training, that the adherence rate is about 50%, right? Because about half of the patients keep this training, but about half of the patients withdraw this training or quit from the training. Is that true?
No, I don't think so. All the patients, we enrolled 108 patients in the intervention group and 109 in the control group. At last, 101, as I remember, and 103 patients complete the total training program of this study.
So the adherence rate is above 95%. It's almost. Right.
Yes.
Okay. Okay. The last question is also about the rate. How many patients will get the I don't know, it's MI scan or CT scan for the imaging study? How many patients get this?
43, because the 7 Tesla MRI scan machine is only available in Shanghai and Beijing.
Okay.
So only a small percent of patients could conduct this examination, and but the 43 participants is already a relatively large sample for the studies of the brain MRI.
I quite agree. It's very important because it is a very objective indication by the imaging scan, and so that's to say about 20%, right? Like 20 for each treatment arm get the imaging study, right? Okay.
Yes.
Okay. Thank you very much for your sharing. Any other questions?
Dr. Guo, very nice presentation. That very interesting study, and also show the trend of improvement in the training program. But the problem is that I can find that there's no significant difference between the two groups. Is that because of the short period of follow-up period, or maybe longer period of training, you can get more beneficial result? Is that the result you expected or unexpected?
Thank you for your question, Professor Zhang. Yes, this study shows negative results. I think it's have several reasons. First, I think it's because we used the active control group. The control group also received the cognitive training, but a little bit simple and fixed, and did not adapt the difficulty according to their previous training performance. And this control group also has improvement in their cognitive functions. So the robust control group may contribute to the negative results. And also, as you mentioned, the follow-up period may be a little bit short. We still need more studies and longer observations to find out the true effects of this cognitive training programs on their cognitive functions. But even with the 12-week 12-week training, we already found some changes in their brain MRI functional and structural connectivities of the intervention group compared to the control group. This may because the functional measurement scores may be less sensitive than the changes of the brain functional activity. So we couldn't find the positive results of the primary endpoints of our study, the score changes. Thank you.
Thank you.
Any other questions?
I just have some comments because my question is the same as Professor Zhang. I think cognitive impairment and dementia cause continuous cognitive decline, which greatly affects patients' daily function and behavior. With global population aging, the prevalence of these diseases is rising rapidly worldwide, bringing huge social and medical burdens. Notable 10 to 15% of patients with mild cognitive impairment progress to dementia every year. There are more. Effective early intervention is extremely urgent. Against this background, this study focused on digital cognitive training in elderly hypertensive patients with mild cognitive impairment. The results show that both adaptive and non-adaptive multi-domain computerized training can improve overall cognitive function and working memory. Importantly, only adaptive training further enhances information processing speed. Neuroimaging findings also prove that adaptive training produces better brain function and structure connectivity, especially in key advanced brain networks and the hippocampus, which is vulnerable to hypertensive damage. So the multi-domain adaptive training can boost brain neuroplasticity and effectively slow cognitive decline in high-risk hypertensive populations. So for future research, I think we need longer follow-up to confirm how long the neuroprotective effects can last. Meanwhile, it is worth exploring whether longer follow-up can reveal more significant differences between adaptive and non-adaptive training. We can also optimize personalized training for different age and hypertension subgroups. That's my short comments. Thank you.
Okay, thank you, Professor Xu. Okay, any other questions? If I can follow Professor Xu, and it's an open question because if you, in the future, afterward, if you have another fund to do another trial? Professor Guo, what do you plan? I mean that if you will randomize like the adaptive training and also the placebo, that there is no positive control group, because it makes sense. But for the endpoint outcome that you will choose the imaging scan, what is your plan in the future, or the longer follow-up? If you have money, that's the next trial after this one, what do you plan? Because I think if you use only the primary endpoint, if it is only the subjective scoring results, you need to do the double blind. But if you have the imaging, it's very objective endpoint, primary endpoint. So you can use the single blind, not double blind. So you use the positive training and the placebo, no training. So I think maybe it makes sense. What is your plan? It's an open question.
Thank you for your suggestion, Professor Zhang. Yes, in this study, I think one of our limitation is that we don't have the placebo control that without training. So we can only compare the effects of adaptive and non-adaptive cognitive training, and the result is negative. This setting of this study, as you mentioned, is because if we have the sham or the placebo group, the patients we know it will stop the blinding. The MRI scanning is objective endpoints to evaluate patients' cognitive changes. Yes, but the 7 Tesla MRI is very expensive.
Costly. Yeah, I know. It's very costly.
Yeah,
exactly.
and
I think it's also you can try to follow up this patient, because you can.
Yeah.
Currently, you stopped the intervention, and then in the open follow-up period, and then follow up maybe another 24 weeks or even longer to see whether these parameters return to normal, return to the baseline. Those will have indicate that this training program is effective or not.
Yes, very good suggestion. Thank you.
Thank you very much. I think lastly we will welcome Professor Zhang give us closing remark.
No. I cannot go. I cannot summarize, because it's very comprehensive, very informative information to share with us. Our 2-3 experts gave a very excellent presentation. They are very high quality studies, and in our region, in Asian region, and they also find that currently we face big problems, not only for stroke, myocardial infarction, but also for chronic diseases, dementia, also kind of a big problem for the elderly, even not only elderly, but also maybe the midlife population. That's something we have to face up to. And also, we realized that the antihypertensive treatment is effective in reduce the cardiovascular events. Also, also shown by effectiveness in the management of dementia, or delay the development of dementia or cognitive dysfunction. That's very important. And also, I appreciate your contribution. And this data also find to be. I think it's just a starting point to start a new era. Just as introduced by Dr. Guo, it's very interesting to find that training program in the reduction of improvement of cognitive function. That's also a very hot topic. So I would maybe that because of the limit of time, we have to stop they finished our session here, and I also want to thank our 3 or 4 co-chairs, and also our 3 speakers for your excellent contribution. And we'll see you next time. Thank you. Thank you very much.
Okay, thank you.
Thank
Thank you very
you.
much.
Thank you.
Okay, bye-bye.
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 Bye.
Bye-bye.
Bye-bye.
Bye-bye.